For Dr. Shicham, and thank you so much for joining us today. I'm going to get started talking a bit about your biography. So Dr. Shicham is a professor of general surgery and the vice dean in charge of research and cooperation at the Faculty of Health Sciences at the University of Buea. He was the head of the Department of Surgery in the same faculty for over a decade. He also served as the Director of Research for Cameroon at PACE, UCLA, which stands for the Program for the Advancement of Surgical Equity. He has designed and implemented a curriculum for undergraduate training in general surgery for the university and teaches a module on non-communicable diseases to MPH and PhD students in the Buea Department of Public Health and Hygiene. He has mentored over 90 medical students, 20 MPH students, and 3 PhD students in their research. Dr. Chicham's research work has been oriented toward improving the care of the injured in Cameroon. He developed a collaborative program with research partners at UCSF and UCLA, with whom he designed 2 programs earning funding from the NIH. He co-mentored numerous trainees from UCSF and UCLA, serving as the Cameroon's mentor and direct supervisor for the in-country field work. Thank you so much, Dr. Shicham, for joining us today.
Thank you. That's so nice of you. That is really, you've said everything about me. I don't even feel like saying anything anymore. Thank you very much. I want to thank everyone who made it possible for us to have this discussion today. I consider it a great honor talking to young medical students who are the future. I hope we get a number of surgeons from them. So it's great time. I will use, let's say I take like 30 minutes to take you for a tour of Cameroon with an insight into issues relating to injuries and the health system in general in Cameroon, so that maybe we have a little more time for discussions at the end of the presentation. So I am in University of Buea. Dr. Juliet and myself, we belong to a number of groups with an interest into issues regarding surgery, global surgery, anesthesia, and equity into surgical practice in a number of countries. So that's what we are. My slide in changing just 1 minute. Okay. If you permit, during this tour, I'm going to take you, first of all, tell you whom we are. I want to believe that some of you quickly checked in Google to see what Cameroon is all about. I'll just give you a few facts so that I situate you into the problems we're going to discuss today. I'll give you the reasons why Dr. Juliet, myself, and all the team members believe that we should care about injuries probably more than anyone else should. Then we'll share with you what we know already about the problems of injuries in Cameroon. Then give you an idea on how we think the problems related to injuries in Cameroon and in other sub-Saharan African countries with similar characteristics should be tackled. And finally, we will tell you what is the way forward from what we have achieved all together so far. So let's go to Cameroon. Many of you at some point in time will apply for a global fellowship. I was honored to have a good number of students from UCLA, UCSF in Cameroon under those who are interested actually in global surgery. We always make sure that they have the opportunity. And I'm receiving more and more students from UCLA. Ami was here. Before Ami, I had Dennis Zeng was here. Currently, Mark, a resident in surgery, is here, Mark Yost. So we are really privileged, and we think that the number of students from US who are going to get interested in what we are doing is going to be increasing. And I hope you choose Cameroon when the time comes. If you see the map of Africa, Cameroon is somewhere here at the heart of Africa. This is, I'm somewhere here. Buea is somewhere here. Can you see my cursor? So what you see here is Mount Cameroon. It's a small country, nothing to compare with USA. It's a poor country with like $2,300 of as GDP per capita, just to give you an idea. And I will keep comparing. For you guys in US, it's 63K. 27 million people, nothing to do with the 330 million of Americans. Life expectancy in Cameroon in 2019 was still estimated to be 59 years. Nothing to do with 76 years of USA, which is still quite low if compared to other countries like Denmark or Sweden, who are above 86 and this kind of thing. So that's an idea of what Cameroon are. For those of you who will choose to come visit us in Cameroon, I will take you to Boya. Boya is at the foot of a mountain. It's a volcano, actually. It enters into an eruption like every 10 years or so. And here in Cameroon, we don't fear the lava that is flowing from the heart of the mountain, because every year we organize a race here for those who like sports. So we go on top of the mountain and come down. It's only 4,800 meters high. So every year there is a Cameroon mountain race. But the only problem I have is for those who are going to join me for the Cameroon mountain race, I advise you do everything to avoid being injured, because it has been established long ago that for countries like Cameroon, as compared to a city like Los Angeles where you live, for the same type of injury, I mean, it's an injury of similar severity, I'm twice more likely to die if I'm in Cameroon than if I am in Los Angeles. And the reasons are this: if you want to avoid people dying or sustaining a permanent disability as a result of injury, the care starts before the hospital. It's all about 9/11, paramedics rushing, takes an average of 6 minutes to get an ambulance to where the person is, picking your hip up. The treatment starts before we even get him in the ambulance. Generally, you all start by inserting a neck collar to prevent any damage to a cervical spine. So it's well organized. Then in the hospital, there is a whole system in place to make sure that patients who arrive in the hospital are efficiently taken care of. And when one hospital can't handle the case, there is a whole referral system well organized to take patients to where they need to go to. And once they leave the hospital, there is a rehabilitation system well organized as well. And that is the reason why the outcomes between Los Angeles and Boya are completely different. The problem is, in Cameroon, although we have a health system which is stratified in 5 levels, from primary care level to reference hospitals, which is, one can say, is the equivalent of trauma center in Los Angeles, so that I'm sure we're speaking the same language. But although it is organized like that, issues that are considered major public health problems in Cameroon are coordinated at the central level. This is the case for tuberculosis, for HIV and AIDS, and for malaria, just to pick up these 3 examples. One of the issues we have is that though we have a few insurance companies offering health insurance, most people can't pay for that. So the vast majority of people don't have an insurance system. And we don't have any universal health coverage that is functional. So the consequence is, if you get injured on Mount Cameroon when you follow me there for a race, you're going to have to pay out of pocket. And when I say out of pocket, for every care, including blood, because we perform some tests on blood, including HIV, syphilis, and other, you have to pay for these tests. So you will have to pay for blood, and we don't accept credit cards, only cash in our hospitals. So that is the main difference between UCLA and University of Boya, where I'm located. So we thought there was a problem. We thought like 15 years ago that there was a problem. I started discussing with this cute lady who happened to travel in Cameroon, and realized that I was interested in changing the situation of injuries in Cameroon. Then we got some support from the Ministry of Public Health. We created a number of specific structures like the Center for Global Surgical Studies when Dr. Juliet was still at UCSF. When she came to UCLA, we turned it into PACE, which some of you have heard about. And what we've been trying to achieve for the past 15 years is, first of all, improve the care of the injured in Cameroon, because we think that it's not done at the optimal level. And the changes that we want to implement in Cameroon, we hope we can translate them into changes for other sub-Saharan African countries with similar characteristics. But also, I will tell you a little bit about it. We want to bridge the gaps of the inequities to access to surgical care. Clearly, you can understand them easily. If you have to pay to get handled when you are injured, or when you have whatever type of problem you have, whatever surgical problem or medical problem, obviously, those who have money will get good care. Those who don't will have crap. So we're trying to figure out a way of bridging this gap, and that's what we've been doing for the past 15 years now. This is the reason why we think we should care about injuries. Globally, we're talking about nearly 6 million deaths every year, and these are the reports from WHO, 6 million deaths everywhere worldwide, 16% of the global burden of disease, 650 million people living with a disability. That was in 2004. It has probably increased. But the reason why we think it's more of our problem here is that though you people possess all these quality systems and everything, 90% of these cases of injuries still occur in low and middle income countries like Cameroon, and 80% of the disabled live where we are. I don't even want to mention this significant amount of economic loss and all other social economic consequences. Now, let's talk about how these deaths are analyzed in a typical sub-Saharan African country. Injuries, I told you a while ago about these three major public health problems which are coordinated at the central level. Nobody seems to have realized that injuries alone kill more than these three other public health problems combined. Nobody seems to realize it, and this is the reason why we sometimes refer to injuries here as the neglected epidemics. Focusing more on African countries like Cameroon, 78 million people living with a disability in 1998, projected 125 million by 2035, and we still believe this is an underestimation. And the other thing that is obvious in the existing literature in sub-Saharan African country is that most of it actually happens on the road. This takes me to two very interesting images that I like to share whenever I'm talking about injuries in Cameroon. How do you want the road to be safe in a place where you can have a signboard indicating a bend to the left, while the bend is actually to the right? Something like this happens in the system in Los Angeles. Someone will have to pay for such a mistake because there are going to be consequences. Or this kind of crazy traffic situation that you only see in some sub-Saharan African country, with two people trying to overtake over a bend, and they don't seem to realize that the signs that are on the right by the side of the road are to inform them that some people died not too long ago exactly here, trying to behave crazy the same way you guys are trying to do. So it has to happen. So we just felt that we must do something to change the situation. We are surgeons. I'm a general surgeon. Dr. Julia is a trauma surgeon. We are academicians. That's why we like spending time talking to students. So we are academic surgeons. And if you want to change something from the academic surgeon's approach, you rely on three different approaches. The first one is improving the clinical care with all it takes, improving clinical care. That's the number one thing. So we must be in the hospital. But because while we are in the hospital, we can only handle one patient at the time, we need to provide decision makers who make decisions about thousands of people with information which are relevant. So it must be about research, and research must be problem-oriented. You must have identified the problem involved. And finally, we need to educate those who are going to take over at multiple level, undergraduate, and also postgraduate, and also mentor young researchers who want to get interested into what we are doing. That's what we've been doing for the past 15 years now. And thanks to what we've done so far, we know one or two things about injuries in Cameroon now, because until 2009, when you checked about data availability, we realized quickly that the main problem is data scarcity. We knew nearly nothing. In particular, we had no epidemiological data estimating the magnitude of the problem. So the first thing about it was to collect some baseline information, which resulted in the publication of these two articles, then institute a first trauma registry, which we started in Cameroon. What is it all about? In US, not only in UCLA or in Los Angeles, every trauma case is registered somewhere using the same set of data. So there is a truly national trauma registry in the United States, same set of data everywhere, so that you can now extract for a particular area, analyze, and come out with specific conclusions. We don't have any such in Cameroon. So we started with a pilot register, which we opened in 4 hospitals, 1 central hospital, one regional hospital, 1 district hospital, and 1 mission hospital in Cameroon. And for the few years that this was functional, what we've been able to, actually everything I'm sharing with you now, which we know about injuries in Cameroon, come from, first of all, our Cameroon Trauma Registry from the 4 pilot center, but also from a community study, community-based study that we carried in 2015, which permitted us to reach more than 8,000 individuals. And all these data, we use them to run 2 NIH-funded projects. One of them is about improving the quality of the care received by trauma patients. And the other one was about following up patients at home after they have been discharged from the hospital, because we realized that once patients leave the hospital, some of them leave the hospital still having a problem, and tracing them back to be able to identify the problems they have after leaving the hospital is not that easy. So we know 1 or 2 things. We know the most basic information about data now: demographics, injury context, mechanism, the clinical findings, presentation at the hospital, the practices, the treatments that we receive, the guidelines, everything. And by the way, we've been able to shift recently from 4 sites to 10 sites. So we're making some progress. So at least we know this. There are other things that we know. Unintentional injuries represent more than 3/4. I'm not particularly proud of that, but I love to compare it with data. There is less violence here in Cameroon than in US. And it makes sense, actually, because in US, you have this issue. There's something that's never going to happen in Cameroon, like Las Vegas, someone, multiple machine guns, shooting at people, killing 58 people in a row, and this kind of thing. This is never going to happen to Cameroon. I've never seen a gun out of the hands of a policeman or an army. We have no idea what that is. So there is less violence, more traffic-related injury, more domestic injuries, more falls, more labor-related injury, because our system is not as protective as yours towards workers. So that is one of the big differences that you can observe. Yes, a lot of things happen in the road. This is the road between Douala and Yaoundé. These are the 2 largest cities in Cameroon. Sometimes it collapses and you have to start everything again, as you see here. But the main characteristic of this road is that you have some straight lines. In straight lines, it's actually demonstrated that people tend to speed. Nothing like the major highway with 4 lanes on each side, separated by something in the middle. No, everyone is on this road, moving this direction, and the other ones coming this direction. Sometimes you have bends on kilometers, not making it possible to overtake. And those who are behind trucks, as you see here, get impatient. Then they start overtaking over a bend, and you find yourself with this kind of dramatic situation where no one survives a crash. Yes, a lot happens in the roads on Cameroon. We also learned that the incidence of injuries in Cameroon is 63 injuries per 1,000 people. And that 113,000 people per 100,000 population die every year as a result of injury. This is very far. This, by the way, double what you people record there in the United States. But it's 4 times what was officially reported by WHO, confirming that only a community-based study can actually reveal you the real picture of the impact of injuries as a neglected epidemic, as I mentioned earlier. And we confirmed that it was more than HIV, tuberculosis, and malaria combined. But we found things that are even more scary. For example, if you get a cut in your kitchen in LA, you call 911, they come and pick you up, it's going to get stitched, or they'll do something like a compressive dressing to, but it's hospital. Here, only 44% of victims of, only 56% of victims of injury go to the hospital. The other ones don't. Either they go home for treatment, and you guess the reason is they don't want to be asked to pay because they don't have the money. Or, and we can't neglect this, they go to what we call here traditional healers. These are people who rely on some traditional knowledge from African culture to propose treatment for a number of conditions. But also we discovered a number of other terrible things. We have more than 70% of people who left the hospital who are at home with either a severe or a moderate disability. People are at home after leaving the hospital, but they are not feeling fine. They still depend on a number of other people to perform the most basic duties, like feeding themselves, like toileting themselves and all this. And that's why we thought that after we discovered that, yes, they don't have money for treatment in the hospital, but they all possess an Android phone. All of them, 93%. Believe me, I don't know what is the most recent iPhone that is to be released by Apple. I'm not doing any advertisement. I think it should be $1,500. I can assure you that some of us here in Cameroon get it before you there, you guys there in America. So 93% of people possess a cellular phone, and we thought that was a great opportunity to use to be able to follow up people at home. Now, why do people not receive the treatment for those who come to the hospital? We have a lot of them who actually come to the hospital because they have no option, but they don't receive any treatment either because they can't pay, 45% of them, or because they prefer to go back home. And guess what? Most of the times they prefer to go back home precisely because they can't pay. So that is the problem we have here. We looked at those who die. We realized that most of them die in the emergency room. We realized that half of them die of brain involvement. And it's shocking because in Cameroon, I don't want to shock you by telling you that for the 27 million inhabitants of Cameroon, we got 26 neurosurgeons. That's one neurosurgeon per 1 million inhabitants. And these people are all focused in Douala and Yaoundé, the 2 largest cities in the country. We realize that some patients still bleed to death in the emergency department, sometimes because we cannot handle them properly, lack of equipment and all these kinds of things. So based on that, we realize that nearly 80% of death, injury-related death in Cameroon are actually either preventable or potentially preventable with simple measures. And we think we are now trying to leverage on this to be able to improve the care of the injured in Cameroon by imposing a structural approach like ATLS on everyone. We're working hard on that. By providing protocols, we're working hard with a few neurosurgeons so that we can provide caregivers with a protocol that permits them to at least give minimum care to all patients with a traumatic brain injury in the absence of a neurosurgeon. So now we're thinking about ways to address the challenges related to obtaining blood products to be used on our patients. Now let's look at those who were discharged home. As I told you earlier, they all have the most recent Android phones. So we called them 4 times. 2 weeks after discharge from the hospital, 1 month after discharge, then 3 months after discharge, and another one 6 months after discharge. We use a simple tool to check on how they are doing. Actually, they are very simple questions. The first one is, are you alive or dead? Obviously, if the answer is, I'm dead, we drop quickly because we don't like talking to ghosts here in Cameroon and Africa. But checking on this, we realize that 90% of the post-trauma, the post-discharge death actually occurred within 2 weeks of discharge from the hospital. The lesson is, we are discharging patients when they are still quite sick, and many of them go and die at home. Guess why? Probably because at some point in time, they can't pay for their care and they prefer to discharge from the hospital and go home. Now, 22% of those who left the hospital after 6 months are still carrying a heavy disability. So we've begun to have an idea of what happens in the hospital, how we can change it, what happens when they leave the house and go home, how we can change it, and now we are thinking about the way forward. The way forward relies on the academic tripod that I told you people about earlier. First of all, research once more, networking, capacity building, that is training, while we keep taking care of individual patients in the hospital. So we're recently able to secure 2 projects, 2 research grants, NIH-funded projects. One of them permitted us to expand our trauma registry from the 4 pilot centers to 10 hospitals. Now, we are good. We are gathering data massively and making good use of them. We're going to share with you when we have the opportunity what we have achieved so far. We are using this massive data to run 2 projects. The first of these projects is about providing healthcare providers themselves with a tool that will permit them to measure economic status and identify patients who will need to be assisted during the process of care, economically assisted. Then we want to optimize the follow-up of patients by reinforcing what we started with the mHealth project that I just told you about a little earlier. The other one, the other grant that we secured is a training grant. We are going to train a critical mass of researchers with a specific focus on trauma and injury for the upcoming 5 years. Hopefully, by the end of that program, we would have had really a good number of master's students, PhD graduates, master's graduates, PhD graduates, who are going to join us to form the team that we believe is going to be game-changing in Cameroon. Don't want to give you too much details about that, but we believe that from the few scarce data that we, the few staff with a few trainees we're collecting, we now been able to organize it into 2 really structured projects. And our final ambition is going to be to have a real data center in the University of Boya, which is going to help us handle the issue more efficiently. Now, coming back to Mount Cameroon, this is not exactly going to be the ambulance that will be used to take you if you get injured, but in some areas of Africa, you still have to use this kind of ambulance, which is dragged by a cow to be able to get you to the hospital. I don't know how long that's going to take, but I thank you for listening, and I will be open to any questions you might want to ask or any ideas that you might want to share. Thank you very much. Anyone out there?
Hi, good morning, Dr. Chisholm.
Hi.
I would like to learn a little bit more about the Stream Cameroon and what the training might look like for some of the improved medical interventions that you might want to have in Cameroon.
Okay, thank you. The STREAM program is about, in Cameroon, we have a lot of qualitative studies. What we need is data. So the training we are having is completely focused on quantitative data analysis. We want students who will know how to handle big data, because hopefully by the end of the U50 program, we hope to have data about like 35,000 patients. Now we're talking. We want people who are capable of analyzing it in terms of quantitative analysis. So what we offer to them is they are all registered either with the MPH program or PhD in the Department of Public Health. We only want people in the Department of Public Health of our faculty here. Now, parallelly to their training, which they receive in Boya, we offer them additional training, which is all about quantitative analysis with the support of Berkeley, mainly, and UCLA. So they have to take additional courses with Berkeley, UCLA, African Institute of Mathematical Sciences, and it's all focused on quantitative data analysis. So that's what the STREAM program is all about. By the end of the STREAM program, we hope to have trained like 24 people who are going to take over the data center that we plan to create in the University of Boya. We actually want to extend the reasoning beyond injuries, surgery in general, and anyone who is interested in big data, no matter the area, we'll get someone. We're not going to have someone who is available to help them analyze big data. They're already good at R. You know about the R program? Still don't understand how a program can be called a letter, R. Okay, thank you. I hope that answers your question.
Yes, it does. Thank you.
You're welcome.
Thank you so much, Dr. Chichon, for the talk. I find it really interesting, and I really appreciate you coming and talking to us today. I'm interested in a little bit more about your personal motivations to become a surgeon. I was just wondering, like, what made you decided that you want to go into the specialty of general surgery?
In Cameroon, the training system is not exactly the same. You have to complete general medical education, then work for at least 2 years before returning for a residency program. So I actually chose to work for 4 years, and I served in a gastroenterology unit in a central hospital, in a big hospital in Yaoundé. Then I realized that there were a number of problems which internists can't solve. So initially, I wanted to be a visceral surgeon with the idea of solving the problems of the digestive system that the gastroenterologists could not solve. And at that time, digestive surgeons or visceral surgeons in Cameroon were not too many. So I decided to move into that. Then at the end of my residency program as a surgeon, I was sent to Limbe, which is a small semi-urban city near Boya, like 27 kilometers from Boya. I never left Limbe anymore because I quickly realized that 2 things. The first thing is half of the patients, no, rather 80% of my activities as a general surgeon were emergencies. So I was like, where are the guys with uncomplicated problems like the uncomplicated hernia? Where are they? And that's where I realized that it was all about equity. They are at home. They can't come to the hospital because they can't pay. And they only come to the hospital when the hernia gets incarcerated. So I quickly understood there is an issue with equity. Now, among these 80% of emergencies, half of them were injuries. So I knew there was a problem with injuries, and that's the time that I got interested into both injuries and surgical equity. That is global access to surgical and anesthetic services. I can assure you that I've done some. I moved into the entire region where I stay, from one hospital to another, and counted the number of surgical interventions that were offered to the population of the FACO division. That's the name of the division where we are located. I realized that actually it was inspired by the WHO recommendation. According to WHO, if you want to solve the surgically correctable problems of people in a country like this one, you need to perform 6,400 surgical interventions for 100,000 people every year. So I counted and realized that what we are offering is 2,200. So clearly, 4,200 people per 100,000 inhabitants stay at home with their problems. They don't come to the hospital. We call that unmet surgical needs. So we really have a problem with global access to surgery, and this is one of the things that we're trying to figure out the best way to solve it. Hope that answers your question.
Yeah, no, it absolutely did. I know that Akif has a question, but I'll ask my follow-up question after.
Okay.
So I'm interested if there's anything at the policy level, at the national level, that's being done to sort of reduce some of the health inequities there. So you had the picture about the road sign that didn't quite match up with where people are actually driving. Is there anything immediately being done at the national level to sort of improve, like driving, road sign and stuff like that?
Actually, thank you for your question, Akiv. Do I say Akiv?
Yeah.
Okay, thank you. In terms of law and how do I put it, system measures, we got nearly everything in Cameroon. The problem is implementation. That's where we got a problem, implementation. If you come to Cameroon, you can't drive too fast right now for two reasons. The first one is there are speed breaks everywhere. And the problem we have with speed breaks is that they sometimes cause more trouble than they solve because people still drive with high speed on the speed break and their cars capsize. Also, you have radars, and when leaving your home, you have no idea where the radar is going to be. So you easily get caught. The problem is, for another aspect, is you can't drive a car without a certificate of technical visit. One of the most serious offenses in Cameroon is driving without a license. Not accepted. So we have all that. The problem is what use we do of that. I don't want to enter into issues regarding, some specific social issues like corruption and these kind of things, which are a problem into implementation of the law. There is a whole think tank which is all about preventive measures on the road. You have road safety squads everywhere. You don't know when you are going to meet them, but the problem is that they have no impact in terms of prevention because the system has its own specificities, which really make it difficult to implement the law. I'm sure you understand what I'm talking about.
Yeah, I understand.
Okay.
Hi, good morning, Dr. Shisham. I had a quick question for you. First of all, I just want to say thank you so much for your time this morning. But in the past, I done research on emergency response in Cameroon's neighboring country, Nigeria, and there's quite a lot of similarities in that area between these two countries. So I was wondering, in your opinion, how feasible do you think civilian response to either reporting or responding to road accidents would be in Cameroon? I know Cameroon is multilingual and also multicultural, so would you expect to see any differences between these different regions in terms of responses? But also, I just wanted to know if you think empowering civilians would be effective in responding to all these roadside injuries.
Thank you very much, Naomi. We are at the heart of what we are brainstorming on. Now, as I said, we want to be efficient at least 3 levels: pre-hospital, then in the hospital, then after discharge. We've done some work in the hospital so far. We can provide healthcare, caregivers with a number of guidelines which we are working on. It's all about adapting, it's not about offering substandard care because they are poor. No, it's about giving them the same standard of care, but adapting the guideline to the environment, that is the infrastructure, the equipment, the human resources, and all those things. So we've done some work on that, and we believe that if this is implemented, it's going to be game-changing. We want to move, we've started moving out of the hospital after discharge. So we call them, ask them how they are doing, and if based on the information that we collect, we can estimate how good or how bad they are doing and make a decision on how to advise them. We ask them to come back to the hospital. In the previous phase of this project, we assigned a specific doctor in one of our 4 pilot sites to take care of them, and we paid the doctor. Now, we're just encouraging them, we're telling them, your condition is really bad, you are likely to suffer a permanent disability, could even be in danger of death, but we think you should actually go back to the hospital to avoid that. Now, we are exploring rehab because no rehab services are offered. We've assigned one of our postdoctoral fellows right now to collect a number of basic data on what is actually being offered to injury patients in terms of rehabilitation. Now, let's move out of the hospital again, but before the patient comes to the hospital. We have an ambulance system which is inspired by the French SAMU. Don't know if anyone ever heard about the French SAMU. The problem we still have, same problem. You give a call to the ambulance system and say, I got an injury, I'm located here. And the first question they're going to ask you is, how do you plan to pay? We can pick you up, but the cost is going to be like $150. How do you plan to pay? So it's totally inefficient. Based on an experience from some other African countries, we believe that the way forward is going to be lay first responder. Most traffic-related injuries occur with these guys who are riding motorcycles. And I'm sure Naomi understands that very well if she ever visited Nigeria, because it's the same picture there. We are now mounting a project to be able to train motorcycle riders to give a real, to be able to condition the patient properly and stabilize him and safely take him to the hospital. That's going to be the first window we're going to open into pre-hospital care while waiting for the system to turn into something that can actually efficiently take care of that. But there is hope. For now, recently in a country like Cameroon, there was a political decision to institute universal health coverage. For now, it is limited to a number of basic services, but hopefully it's going to extend gradually, and we hope to be able to guide them on what are the most urgent aspects of injuries that should be covered by that universal coverage, which is still embryological at this point. Hope that helps, Naomi.
Absolutely. Thank you so much.
You're welcome.
Hi, Dr. Chichom. This is Ezzy. I also grew up in Nigeria, and as far as the ambulance situation that you were talking about, I wanted to ask what qualities do you think that Cameroon has that would make ambulance more effective? Because some of the problems that comes up with the effectiveness of having ambulances is distance to the hospital and good roads and stuff like that. So I was wondering if you could talk more about even if you had more ambulances, what other challenges would you face in a country that you want to establish that in?
Thank you, Izzy. Yes, two major we think about that a lot. Two major challenges. Number one challenge is going to be to keep the ambulance system functional. But believe me, it's as easy as decentralizing. No hospital in Cameroon is autonomous. Hospitals in Cameroon are actually centrally managed. Ministry of Public Health. You need an ambulance, Ministry of Public Health buys it and sends it to you. If the hospital are left with enough autonomy in their management, hospitals definitely can locally create and manage an ambulance system for the area. When I say hospitals, I mean autonomy under the responsibility of municipal authorities who make decisions for themselves. That's going to be the number one challenge. The number one is going to be about human resources. But guess what? We just started in Boya a residency program in emergency medicine. I was lucky enough to contribute largely in designing the curriculum for that. And we're going to make sure that from now on, Cameroon is going to train 10 emergency room physicians, including on how to handle an ambulance system like that one. So we're making some progress.
That's great. Sorry. Also, I wanted to follow up on what you talked about with the training, like the people that ride the bicycles. Man, I thought that was like a pretty great idea. But is there any support from like the Cameroon government with that? And like what incentives would these people have to basically help be bystander or not be bystanders and like help people when they're injured? As well, like, is that like just a thing in Cameroon where everyone cares about each other, or like is there some kind of like incentive that they have to like being like, wanting to be trained to respond and also like responding when something actually happens?
Actually, we are still really exploring the idea. So far, all we've done is have a talk with these guys in Limbe, where I reside, and they are extremely enthusiastic about being given some responsibility to take care of themselves because they are involved in more than 70% of these traffic-related injuries. So they are extremely excited about it. We secured the collaboration of a number of people from the Ministry of Public Health, but hopefully, I think it's the first result of the pilot phase that we're trying to implement that is going to serve. But there are other countries that are doing better. In Uganda, they have gone a little bit further. They don't only train this guy to provide first aid and safely carry the patient to the hospital, but they train them on how to respect traffic regulations. They train them about traffic regulations. And they also give them some ethical training. These guys in Uganda, the Ugandan people, they call these motorcycle drivers boda boda. So there is a system in Uganda now called Safe Boda Boda. That is a motorcycle driver that if you get injured, you're somewhere, can't call an ambulance, you call the number of the central coordination of the Safe Boda Boda, and the person who comes to pick you on his motorcycle is someone who has some training, both on providing first aid and safely taking you to the hospital. So we can push, we are totally open to a number of ideas as we are still in the exploratory phase of that project.
Yeah, thank you. Thank you.
You're welcome. Anyone else? Okay, maybe feel free, please, if you have any additional question, do not hesitate to get in touch with me through the organizers of this. Vaswani, are you there?
Yeah, thank you so much, Dr. Chichome, for taking the time out of your day. I know it's probably the end of a long day for you. For us, it's just the beginning. So we very, very much appreciate it. We will definitely share your slides, the recording, as well as your contact information with all of the students. I know the students all have, I think, an 8 a.m. class, which is probably why everyone is either not on camera or not asking questions, because they're probably rushing to class at the moment. But we very, very much appreciate it. And thank you very, very much for your time.
You're welcome. I appreciate, thank everybody for being able to be part of it. I hope this helps. Thank you.
Perfect. Thank you. Bye, everyone. Have a great rest of your day.